Okay, so in this next session, is titled the NIA Alzheimer's Association Revised Criteria for Diagnosis and Staging of Alzheimer's Disease. The overall goals of the session are first to review the latest version of the criteria, which, as most of you are probably aware, came out just very recently, within the last week or so. And there have been some substantive changes in response to feedback from the public and from the scientific community since the criteria were first presented back at AAIC. So I encourage everybody, if you haven't had a chance to look at them yet, to go ahead and take a look. They are dense, but very, very informative. And so we're going to review those criteria as they currently are proposed. And again, to emphasize to folks, they are still considered a work in progress. So this is not the final set of criteria. And part of the reason for us to have this session is so that we can all be aware and take responsibility for making suggestions, for providing constructive critique. It is really on us as the scientific Alzheimer's and clinical Alzheimer's community to help refine these and make these as effective and broadly applicable as possible. And so to that end, we seek to provide a balanced view of implications for science and clinical practice in general, and then also for our own network in particular. So our format will have presentations, brief presentations on selected topics related to the criteria. It will hold questions until we complete those presentations, and then we have a fairly generous period for discussion, for questions and discussion. So here are the folks that will be participating in the panel. Dr. Cliff Jack. When Cliff was asked how he wanted to be described, he said, "I'm an Alzheimer's researcher." So that's how I'll describe him. He's an Alzheimer's researcher at Mayo Clinic ADRC, and he chaired the work group on the proposed criteria for preclinical Alzheimer's disease. So he'll provide us with a summary of the revised criteria. Mike Raffi is professor of neurology and the medical director of the Alzheimer's Therapeutic Research Institute at the Keck School of Medicine at USC. He also was a member of the committee, so he will provide some additional information about the criteria, as well as present some thoughts about what their impact could be potentially on clinical trials and clinical practice. Dr. Gladys Maestra is the co-director of the South Texas ADRC, and she will discuss the impact of the criteria on diagnosis and treatment of underrepresented groups. Dr. Ali Atri is associate director of the Arizona ADRC, where he also leads the clinical core and is co-leader of the biomarker core. Dr. Cindy Carlson is the clinical core leader of the Wisconsin ADRC and co-chairs the Clinical Task Force Clinical and Diagnostic Measures Committee. And then finally, Dr. Donna Wilcock is on a plane. She may be here in person, we hope so, but we do have her presentation pre-recorded, and hopefully she will be here also in time for questions. But she is chair of the NAC Biomarker Steering Committee and director for the Center of Neurodegenerative Disorders at Indiana University, and she will be discussing inflammation or vascular integration into the criteria. So I'd like to welcome to the stage Dr. Cliff Jack, who will lead us off. You might need that.
Okay. Thanks very much, Suzanne. And I want to thank Suzanne and Gil and the ADRC organization for giving me the opportunity to present this on behalf of our committee. Do you have the slides? Oh, there we go. Okay. And as Suzanne said, this is, we view this as an opportunity to, one, disseminate information, but also to gain feedback from a highly relevant community of stakeholders. You see the members of the committee here, the full committee. So this effort was, the Alzheimer's Association was the sponsoring organization, but you can see on the basis of the composition of the committee that there were people, the committee was designed to be broadly representative. You can see academia, industry, different geographic areas, different areas of scientific expertise. This is the outline of the actual document that Suzanne was referring to. Obviously, I won't have time to go through all the details for each one of these sections in the document. I'll just cover the first 3 or 4, and then Mike Raffi will pick up where I let off. So by way of background, as everyone is very well aware, I mean, the NIAAA has sponsored 3 sets of work groups, if you will, that address issues around diagnosis and characterization of AD. The 3 work groups in 2011, the neuropathology work group in 2012, and then the research framework work group in 2018. And a set of core principles have emerged from the efforts of these prior work groups that our current work group really took as the starting point for our efforts. And I won't read all the bullet points on this slide, except to say separation of syndrome from biology is key, and AD is defined by its biology with a number of underlying implications. Now, you might ask why the update at this particular time. What has changed since 2018? Obvious things have happened. So 1, approved treatments that target core disease pathology did not exist in 2018, do today. 2, development of plasma biomarkers where some, but not all, have excellent diagnostic performance. Who could have predicted in 2018 the flurry of plasma studies that have come out and the good, excellent diagnostic performance of some of these. And the final point, which is a little bit of inside baseball, but certainly people who work in biomarkers recognize full well that imaging and fluid biomarkers within a category are not necessarily interchangeable for some intended uses. Major changes from the draft that was initially presented at AAIC, again, I won't read through these bullet points, but one major change that we have tried to do is to clarify the intent of the document. And that is not to serve as clinical practice guidelines, but rather to create criteria that inform diagnosis and staging of AD that are useful for both clinical practice and the research community. So the first thing I'll address is biomarker categorization. This is an area that we have changed slightly since this past summer. This is the first table in the current version of the document in which we categorize fluid analytes and imaging biomarkers on the basis of 4 different criteria. The first is obvious, plasma or fluid versus imaging, the middle column versus the right-hand column. The next is we separate biomarkers into 3 broad groups: core biomarkers, biomarkers 1, 2, biomarkers of nonspecific processes that are nonetheless essential in AD pathophysiology, and then 3, biomarkers of non-AD copathology. Within each of these categories, we identify specific categories, subcategories, if you will, that denote specific proteinopathy pathways or specific pathophysiologic processes. So, for example, in the core biomarker area, we identify the A, or amyloid, category. These would be biomarkers of the A-beta proteinopathy pathway. The T biomarkers, tau, and here we split these into T1 and T2, where T1 biomarkers are biomarkers denoting phosphorylated and secreted AD tau. In contrast, T2 biomarkers are those that denote the presence of AD proteinopathy deposits. we group these into core 1 and core 2 biomarkers on the basis of onset timing. So the core 1 biomarkers become abnormal early in the disease process and can be used for diagnosis, versus core 2 biomarkers, the T2 biomarkers, become abnormal later on. And then you see biomarkers of in nonspecific, N and I, and biomarkers of non-AD copathology, V and S. The second table in the document describes intended use. And you'll notice a difference here. The first table described analytes. Here we described assays. So, for example, A-beta 1 to 42, it's the same analyte, whether it's measured in CSF or plasma. But the assay implementation can be, in this case, it is different. And so here we separate out CSF and plasma into separate columns. The CSF assays, the approved CSF assays, are all hybrid ratios. They're not individual analytes. In contrast, plasma is typically can be used as a standalone analyte, plasma p-tau 217. And so we see in the diagnosis bin, if you will, for intended use, the A and T1 biomarkers, and then these hybrid ratios. For staging prognosis and as an indicator of biologic treatment effect, they all appear. They all have uses in this category, A, T1, hybrid ratios, T2, et cetera. And then, of course, for identification of copathology, we have N, V, and S. I can explain what N is doing in this category later on if people are interested. Diagnosis. This is the section that has undergone the greatest degree of revision since this past summer in response to comments and helpful suggestions that the committees received. So diagnosis, core 1, the role of core 1 and core 2 AD biomarkers. So the position of the committee is that the diagnosis of AD can be established by abnormality on specific core 1 biomarkers. Specific is an important word. Amyloid PET, the approved CSF assays, or accurate plasma assays. And again, accurate is an important word here, and I'll get to what that means, the definition of that, in a minute or two. So core 1 biomarkers are useful for early detection of AD in people without symptoms and confirmation that AD is present as an underlying pathology in someone who's symptomatic. Core 2 biomarkers are typically not standalone tests for the diagnosis of AD, but can be combined with core 1 biomarkers for staging, and in turn provide information on the likelihood that symptoms are associated with AD, inform on the risk of progression in asymptomatic people, and inform on the likely rate of progression in symptomatic individuals. Now, minimum accuracy benchmark. The committee does have a position, a formal position, on minimum accuracy benchmark requirements. So only biomarkers that have been proven to be accurate with respect to an accepted reference standard should be used for clinical diagnostic purposes. And the same criteria ought to apply to PET CSF or blood-based biomarkers. Our position is that the minimum accuracy requirement would be 90% for the identification of moderate frequent neuritic plaques at autopsy or an approved surrogate in the intended use population. Now, as everyone is aware, it was this autopsy standard that was used for regulatory approval of the amyloid PET ligands that are now approved for use. But it was the PET surrogate, amyloid PET surrogate, that was used for regulatory approval of the CSF assays that have been approved. To date, there have been no blood-based biomarkers that have received regulatory approval for diagnosis, although this is certain to change in the near future. An easy way or a simplified form to think about then this minimum accuracy benchmark with respect to the coming, for lack of a better word, flood of blood-based biomarkers is that if they achieve an accuracy in the intended use population equivalent to approved CSF assays, then they ought to be considered diagnostic. Now, the final point I'll make from this slide is this notion of specification of accurate in the intended use population. This addresses the issues of positive and negative predictive value, which obviously depend on the prior probability of AD in the population of interest. Another area of the document that we have made an attempt to really beef up and clarify is this issue that clinical judgment has to be paramount whenever employing biomarkers for diagnostic or clinical purposes. It's particularly the case if a biomarker test result seems discordant with clinical presentation. 2, when assessing the likely contribution of AD versus other pathologies to clinical symptoms. 3, to assess potential effects of confounding medical conditions on biomarker test results. There are 2 very explicit statements in the current version of the document that I don't think anyone in this audience would object to. There might be some objections on by some parties, however. One is that the statement that this committee strongly recommends the clinicians should not be restricted by payers in pursuing further testing if this is indicated in the judgment of the clinician. And thanks to John Graff Radford for really drilling this into my brain, the importance of this condition. Secondly, we recommend that biomarker testing should only be performed under the supervision of a physician, i.e. not direct marketing to patients, bypassing clinical judgment. The last thing I'll address then is this issue of biological disease staging. Staging of AD only applies to individuals in whom the disease has been diagnosed by an abnormal core biomarker. We distinguish between biological staging, which is done by biomarkers, versus clinical staging, which is done by clinical assessment. Our staging scheme is based on the natural history of events, biomarker events observed in natural history studies, and employs core biomarkers only. So this is the primary staging scheme that we are proposing. It's based on PET, amyloid PET, and tau PET. I'll explain the bottom part of this slide in a second. We define 4 stages. So the initial stage of AD, stage A, would be amyloid PET abnormal, tau PET negative, A plus T minus. Early stage, stage B, would be A plus medial temporal lobe positive on tau PET. Intermediate stage, stage C, would be A plus and a moderate level of uptake in a predefined neocortical region of interest on tau PET. And then stage D advanced would be A plus and a high level of SUVR uptake in the same predefined neocortical ROI. Now you can see at the bottom of the slide, there are core when fluid biomarkers. You might ask, what are they doing? What are these fluid biomarkers doing in a staging scheme that's based largely on PET? And it's the opinion of the committee, I'm sure it's no surprise to anyone, that it's anticipated that many patients in the coming months and years will require screening with fluid-based biomarkers, either approved CSF or perhaps plasma biomarkers. And these fluid biomarkers can establish, do they belong or do they not belong in this staging scheme? And so we envisioned then that a combination of a fluid test and tau PET could be used together to do complete staging, as opposed to requiring amyloid and tau PET in everyone for staging. We also include this idea of a conceptual biological staging with fluid biomarkers. We've made some revisions on how this is presented and decoupled, if you will, from staging with PET. But this is still part of the document. I won't go through the details here for the sake of time. So this is the second to last slide that I have. And I think I've covered the first 4 bullet points or first 4 sections in this document. Mike Raffi will pick up where I leave off and describe clinical staging, integrated biological clinical staging, etc. And then this is the last slide that I have. And once again, I want to recognize the contributions of everyone on the working committee. This has been a great committee to work with. People are engaged, people work hard, and the committee's been meeting for about a year now, a little less than a year now. And then I'll finally close by just reiterating what Suzanne said, and that is that this is an opportunity on behalf of our committee to receive feedback, constructive feedback, from members of the scientific community. We take it very seriously. We've received comments or suggestions from over 60 individuals or interest groups to date, which we've used quite a bit in revising the document. And the link to the document, the current version of the document, is at the bottom of the slide. Anyone who has the time or the inclination, we very much welcome your thoughts on the revised version. And I'll stop there. Thanks very much.
And next we'll hear from Dr. Mike Raffey.
Thanks, Cliff, and thanks to the organizers for the invitation to speak today. These are my disclosures. And this is the remaining part of the outline that Cliff went over that I'll be going into in more depth. So clinical staging, just a reminder, applies only to those individuals who have evidence of biological AD. The only change in the clinical staging of AD in this revision of the draft guidance is the addition of stage 0. And stage 0 includes individuals who have deterministic genes or mutations such as autosomal dominant AD and Down syndrome related AD, but no clinical changes with normal biomarkers. This is consistent with the thinking used in other conditions such as neuronal synuclein disease and Huntington's disease. Risk alleles such as ApoE4 are not included in staging because risk alleles define risk, but they do not define a clinical stage of AD. So here you can see the clinical staging for individuals that are on the AD continuum, and stage 0 is asymptomatic individuals who have a deterministic gene with no evidence of clinical change or any other cognitive symptoms, and biomarkers are within their normal range. The remaining stages are, as have been published previously. Stage 1 are individuals who are asymptomatic but have biomarker evidence only or preclinical AD. Stage 2 are individuals who have transitional decline, that is mild detectable change but minimal impact on their daily function. Stage 3 is cognitive impairment with early functional impairment. And stages 4, 5, and 6 are mild, moderate, and severe dementia that we're all familiar with. So how do we integrate the biological staging with clinical staging? Biological staging, as Cliff mentioned, is designated by letters, and clinical staging is indicated by numbers. The columns are the clinical stages, going from stage 0 to stage 6, and the biological staging are the rows starting with A and ending with D. The majority of patients who are on the AD continuum are thought to go through the journey with AD through those diagonal gray shaded boxes, so that individuals who have an early stage clinical symptomatology may have early stage biological changes. However, there may be individuals who have clinical stages that are further along than would be expected for their biological stages. These individuals might have comorbidities or co-pathologies that lead to a worse clinical performance than would be expected. On the other side, there may be individuals who are below the gray shaded boxes, individuals whose clinical stage is much earlier than that would be expected with their biological stage. This may be a manifestation of resilience or cognitive reserve. As Cliff mentioned, we differentiate between biomarker profiles and biological staging. So the biological staging of AD requires only the presence of core biomarkers. It applies only to individuals in whom AD has been diagnosed, whereas biomarker profiles are those that have been carried forward from the previous guidance, and these can include both core biomarkers and non-core biomarkers to characterize the general pathophysiological state of an individual beyond the presence of Alzheimer's disease. Biomarker profiles are applicable, therefore, to all individuals in the population, whereas staging is applicable only to those who have evidence of AD pathology. So this is the full biomarker profile that was shown just earlier, the ATN-ISV. These can be represented dichotomously as positive or negative, or they could be a continuous quantitative scale for each category as necessary. The full multimodal biomarker profile would be used for each category ideally. However, there are going to be individuals who we cannot assess all of the biomarkers. And so we would recommend the use of as many of the biomarkers as possible to give the best resolution on that individual's overall pathological status. There's a lot of support in the last few years on the biological basis of diagnosing AD. Anti-A beta immunotherapy has now been shown to reduce amyloid PET levels below detection thresholds. They result in trends towards normalization of downstream biomarkers. Anti-A beta immunotherapy that reduces fibrillar amyloid PET, amyloid levels as measured on PET, can actually show cognitive decline, and that has led to FDA approval of treatments, particularly in those with early symptomatic AD. And there's been consistency across both successful and failed immunotherapy agents that the amount of amyloid PET reduction is associated with the degree of clinical benefit. So what is going to be the impact of the use of this framework, both in clinical trials and in clinical practice? Well, the aims of the revision are to improve the fidelity of anchoring symptoms to pathology. We want to capture various biomarker features of AD, including co-pathologies. It allows for improved diagnostic and prognostic accuracy, improved prediction of treatment response, as well as potential safety and tolerability. And it provides for a standardized framework for earlier intervention. Some examples include, in the AHEAD trial, implementation of plasma screening prior to moving forward to amyloid PET imaging. And in the Trailblazer-ALZ 2 study, where p-tau stratification and staging was used in that trial design. How this will impact clinical practice is still unknown, and it will depend on how our healthcare system evolves to incorporate these changes and bring them to the most number of patients possible in developing our field. Thank you very much.
Thanks, Mike. And next we'll have Dr. Gladys Maestra.
Muy buenos días. Good morning. Very excited to be here. Okay, where should I point? Okay, I have no disclosures except for my funding by NIH and the Texas Alzheimer's Disease Consortium. I didn't want to leave to the last to show you our family in South Texas. Our leader, Dr. Seshadri, and many of the core leaders and rec scholars are here. You see them. We want to see you in Austin, and if you want to come down to South Texas, please. I felt the need to share some concepts, some core concepts. Impact is change. I'm not mentioning diagnosis or defining a disease. I'm saying a diagnostic process, which is a complex patient-centered collaborative activity involving information gathering and clinical reasoning to determine a person's health situation. I'm also saying the diagnostic process is a cyclical process of information gathering, integration, and interpretation, and forming a working diagnosis. This is what our patients, participants, and public expect. And treatment is not only given a drug, it's the provision, coordination, or management of healthcare and related services by one or more providers. This is the map of the country where you can see 100 counties in the US with the highest ADRD prevalence by race and ethnicity. In the top, you see the non-Hispanic whites, you see the Blacks, and in the bottom, you see the Latinx. And it's not randomly distributed. And I have to say here that we know race represents a social rather than a biological construct. And here is a map of the nation of the counties that have been poor, considered poor for the last 30 years. And if you notice, it's very much similar to the map of the counties with the highest Alzheimer's disease. There was a recent publication, a consensus report on using population descriptors yesterday, where this was mentioned in our sessions, and I want to emphasize that I think that we need to stop using these categories. Otherwise, we are going to be falling in the trap. We are not going to find consistent results based on the continental ancestry. It's a very interesting report, and I think that the conclusion number 4 is that the requirement to report demographics using OMB categories has perpetuated misconceptions or exacerbated typological thinking, and we don't have to do that. We are innovators. So the very first question in terms of minorities and underrepresented populations is, are the ATN-defined biomarkers equally prevalent among diverse population, meaning that everybody has about the same level in relationship to, and there are several studies, and I was torn trying to put together the data. But the very first we had using the amyloid positivity was in 2022, I think, where the highest number of amyloid positive were matched participants, Asian and white, Black and white, Hispanic and white. And what was found was that there was a lower level of positivity looking at amyloid among Black and Hispanics. And I tried to summarize some of the work presented by our colleagues here about the studies done on amyloid PET, CSF, A-beta 42 and A-beta 40, and PET-tau and CSF. And in some cohorts, African Americans have higher and others have lower, and others there was no difference. And this is what we are going to be finding if we keep dividing people by color. But that's what we have, so I want to prove my point. In one study in Texas, the HAPS HD, this slide was given by Dr. O'Brien, formerly the Health and Aging Brain Study, where we have African Americans, Mexican Americans, and non-Hispanic whites. You see that the African Americans and non-Hispanic whites with dementia have a higher positivity rates than those, the African American and non-Hispanic whites, while Mexican Americans have 2/3 of the positivity. And in this study also, presented by Dr. Karin Meeker at the AIC meeting, she found that the A, the T, and the N, but not the V, differ by groups also using the Health and Aging Brain Study. So are ATN-defined biomarkers equally prevalent among diverse populations? No. Are ATN-defined biomarkers equally related to clinical outcomes among diverse populations? And in this summary, really, this abstract, you'll see the 3 main groups: non-Hispanic whites, non-Hispanic Blacks, and Hispanics. This was by our colleagues at Columbia University, and they show that if you look at the dispersion and the trajectory of the 2 last columns, the Hispanic Black and the non-Hispanic Black and Hispanic, you see a more broader distribution and tendency trajectory in contrast with the first column, which is the non-Hispanic White. And here we have a slide from our friends from UC Davis, where they show examples of histopathologic densities of tau deposits and overall density scores and neurofibrillary tangles with several ethnicities such as, or population groups such as non-Hispanic whites, Hispanics from Caribbean origin, Mexican origin, and other. And just roughly, you'll see that they look different, but you know, we need to study, we need more brains to actually study the intra-group variability versus the intergroup variability. And Dr. Meeker also presented this nice slide, I think, about the importance of the imaging markers by group predictive cognitive impairment. And if you look at the amyloid, which is the darkest green, you'll see that in Mexican Americans and African Americans, that's about a third of the pie there, while if you look at the yellow, which is the vascular, non-Hispanic whites have the lowest, for example. And the tau in non-Hispanic whites, the proportion. So are ATN-defined biomarkers equally related to clinical outcomes among diverse populations? No. Are modifiers of ATN-defined biomarkers the same across diverse populations? And this is one table of one of our group results looking at GFAP and comparing Mexican Americans of South Texas, or the TARC. This was the TARC database, Mexican Americans and non-Hispanic whites between within the overall cognitively impaired MCI and dementia. And you can see also association of a BMI, systolic blood pressure, diabetes, tobacco use, and the association between these factors and the results for serum GFAP are different among the groups. The associations is different. This is a figure containing some of the modifiers, risk factors for early onset, and some of the risk factors associated, protective factors associated with both early onset and late onset and different pathways. So in summary, you have a plethora of genetic risk factors, and you have life, and you have medicines that will probably impact different biological domains that will have that the impact of these biomarkers is going to be different from the cognitive and neuropathological traits. So the modifiers are not the same across diverse populations. And just wanted to finish this with an example of the lowest heterogeneity, which is dementia, Alzheimer's, dominant dementia with the presenilin, the PISA mutation. And here you have everybody basically has the same mutation, but you have people with early onset, average onset, and late onset. They all live in very narrow area, geographic area, and the diet is very consistent. And there was one woman, 73 years, without cognitive impairment. She was she had the presenilin 1 mutation. She cultivated roses, and she was very creative. She was a florist, and she stayed free of any cognitive impairment until 73. She had an accompanying mutation, ApoE3 subtype, and they have the imaging. So there was a lot of loads of amyloid, but no tau, not that much tau. And there was another case by the same group, and Jaquil Quiroz in Boston, who shows a man that had the same mutation, but has another variant of the reeling gene. And this man also was free of dementia until he was, I think, 78. So what is the context of use, the clinical context? We have to define, and this is a standard for biomarkers in terms of what is the context of use? What are we going to use the biomarkers for? Is it preclinical? Is it to diagnose? Is treatment course? Recurrence, to look at we still do not know what the effect of the treatments are going to be. And we need to think what is the value for the individual. We also need to address and be clear about the value for us as a scientist and the value for clinicians. So this is the context of use. I think we're going to be discussing this more and more. And they suggest, the authors of this article suggest the different contexts of use with the different biomarkers, doses, as a way to teach and train the public and the prescribers. And finally, I think this is a wonderful image that I love, and I've been using it since it was published about that includes the NIA Health Disparities Network, a health disparities framework, and with the disease biomarkers, and this is very useful to frame the study designs. Finally, I think this is going to be a game changer. This slide, Henrik Zetterberg gave it to me to share with you guys about the blood, detecting the AD blood biomarkers using a finger prick. And I think this is going to be just awesome for populations that are rural or distributed across the nation. So talking to our participants about this, they want to see that we are giving the education and support before we give any results of biomarkers. We know we need to clarify the context of use. The pre-test counseling and post-disclosure support should not be optional. We need to be very cautious about selection and usage of lay language. We cannot ignore the history of medicine when we talk about health and disease and the World Health Organization language about it. Comprehension checks to make sure we are on the same, and avoid positive and negative qualifiers like a positive scan, negative test, and finally a resource that I think is very useful, which is Agri Dementia. Thank you so much.
Thank you, Gladys. And now Dr. Ali Atri.
Hi, everyone. It's a privilege to be here with you to give you some thoughts and considerations about the revised criteria and potentially the implementation across the network. These are my disclosures. I'm involved in clinical trials, interpretation, and IDMCs and education. I'm not on a speakers bureau, and I don't have any stocks in anything. I always start actually with this. This is a very good segue from what we just heard about why we do this. And so let me read this. So human beings are members of a whole, in creation of one essence and soul. If one member is afflicted with pain, other members uneasy will remain. If you have no sympathy for human pain, the name of human you cannot retain. This is as true now as it was in ancient Iran 850 years ago. And exciting science, proteinopathies, PET scans, p-tau, it comes down to persons, people. And we have to take this privilege very seriously about how we proceed with that, because this is really our goal. And this is really, really important in the context that we just heard. And we'll talk a little bit more about that. The 20,000-foot view is this very exciting transitional era that's foundational. We know the trajectory is nonlinear, so we're going to have a lot of advances, and it may outpace our ability to keep up a little bit. But there are many strengths and resources for the ADRCs that make them very well positioned in the front lines to implement, to assess, validate, and enhance the revised criteria. This includes all of you and more, proficiency and multidisciplinary researchers and specialty staff, subspecialty expertise, This is critical not just for the scientific aspects, but for the clinical judgment and the care, consideration, and compassion we need as we actually relay these results back and interpret them in the language we use and how we do it. And leveraging existing and developing new collaborations, consortia, projects. So we have some, in these transitions, we're going to have some challenges, but there are lots of opportunities, and we'll be thoughtful about how we do this with collaborations. So just as you've heard already, I'm going to show some quotes from the revised criteria, but meant to be both for research and clinical care, and it's necessary to separate the syndrome from the biology. And I'm a little bit ahead because the other exciting part is the UDS 4.0 coming out. So some of these things you'll see more tomorrow, but basically the approach is still the same, right? The level of impairment, after you gather the information, you decide on the level of impairment. So in the 4.0, it's going to be cognitively unimpaired, subjective cognitive decline, MCI, cognitively impaired, not MCI, MBI, behaviorally impaired, not MBI, and dementia. And then you knock off the domains you think are affected. You think about the clinical syndrome, and then you use this is the D1A and the D1B to mark off the biomarker evidence that you have. And this comes in the form of yes or no, did you use it? Is it abnormal or not? And is the pattern consistent with disease or type X, like AD? But ultimately, you have to put down an etiological diagnosis. What's primary, what may be contributing, and you have to do this with or without biomarker evidence. So you're integrating the full data available in front of you using clinical judgment. So as you saw already from Dr. Jack, the biomarkers that are being suggested in the revised criteria are very specific. There are minimal requirements and standards that are important to acknowledge, and they acknowledge that clinical judgment is important and paramount, particularly in areas where there may be discordant results with a clinical presentation, when the likelihood of copathology is high, and to assess the potential effects of other medical conditions. And also they make the caveat that really for unimpaired individuals, really in clinical settings, I think, that the testing is not advocated. But of course, we're thinking about the research context, but also returning results. So one of the opportunities and challenges is that there's a diversity of biomarkers that are utilized at every center. And there's not this broad standardization, harmonization with respect to measures, assays, platforms, or as you heard, the well-established reference ranges. So really, it's the standard within that center that is important. So we're going to get more, we have the privilege of getting more and more biomarkers to utilize them. It's going to cause a little bit more heterogeneity and variability. It's going to, in some ways, it's information, but that's going to feed into the clinical judgment. And particularly for the biomarkers that we have less information about, that are less tested. And this is a consideration for the return of results, obviously, in some ways, including for etiological diagnosis. Because again, at the centers, you're using your standards, and you have to presume an etiological diagnosis even for the unimpaired individuals. So the revised criteria are very specific about the core 1 and 2 biomarkers. And as you'll see, the NAC UDS 4.0, when it's going through the diagnostics, the biomarkers part, it looks at, for example, fluid biomarkers. And then if you've used it, you have to say whether this is consistent with a pattern of AD. You're not actually saying which one. So you're not saying it's a A or T1 or T2. So you have these 3 levels you're going to put down. For amyloid PUT, it's more like elevated, no, yes, intermittent. And the task force has been, again, thank you. This is such a huge lift. And you've been doing this in parallel. So this is even more difficult. But for non-core things like N, there's the structural imaging, the FDG PET. Again, you put down whether this is consistent, as you'll see, with a pattern of a disease. You have structural imaging that you can use for the V. And, they've been forward-thinking to put other biomarkers in, to put in, to listing, for example, think about synuclein or other things, and what is it consistent with? But of course, less guidance for things like I. It turns out that if you look at it, the diagnostic mapping can probably more readily be done, maybe from the data in the back end, or maybe even from the forms. And this would facilitate the clinical staging. So you can probably say the kind of, as the document says, kind of unimpaired is like a C1, right? if you have the pathology, subject to cognitive decline is a C2, MCI is a C3. Where do you put in those other categories like cognitively impaired, not MCI, or MBI, behaviorally impaired, not MBI? You have to think of, there may be some tweaks there. Maybe it could be in the C1 maybe category. And then actually right now, without tweaks, there's probably not the level of specificity regarding that's required for the biological staging that you just saw. And I'll show the graph again, the table again. Other than probably the stage A versus a stage B through D, if you have amyloid PET, and you have a that's consistent with an AD pattern, in addition to a core 1 amyloid data to go along with it. So again, this is what was shown, and this is what I meant by that biological staging. And that's going to be more difficult. And then, of course, the integrated biological and clinical staging is going to require some tweaks also, probably for implementation. Even if you can, again, think about the clinical stage 1, 2, 3, 4, and then we can tweak and put the other categories in there. But the column in the first part, the staging, is going to be a little bit more difficult. So what are the opportunities? Harmonization and standardization. You heard about NICRAD. That's great. If you're there, you can get these reports back. There's plethora of data available for amyloid and T1 core biomarkers, for plasma, NFL, and GFAP. But there's an opportunity for standardization. As you heard, there's not the reference ranges. There is for p-tau 181, I think it's going to be published. But again, abnormal, normal, abnormal, indeterminate, those are not there. So a lot of opportunities there. SCAN is going to really, really help, right? With the N and potentially the V. Clarity AD is going to provide a lot of, this ATN data. And let's not forget about neuropathology. A big shout out for that in the ADRC networks. And of course, digital biomarkers. And then there's the CMS lifting the amyloid PET NCD. Yay. And the potential, actually, that we can have more standardized core 1 amyloid data for symptomatic participants that way, which is really exciting. And using some of these markers to inform our clinical judgment about the causes and contributors. There's probably going to have to be some more input and development and harmonization regarding terminology. I think, and Mike talked about, Dr. Rafi talked a little bit about some of those things, and whether you need multiple levels potentially in the future, and how do you have terminology if someone has gone from an amyloid, let's say high level, I'm calling it 3 to 0 or a tau. That would be interesting. And then if you have standardization, harmonization, what's the hierarchical decision rules that we need to resolve discordance between biomarkers and some of the categories to help us aid this clinical judgment? And then maybe with little tweaks, we can either do it with a 4.0 or a 4.1, be able to put in that biological staging and also the integrated staging. So in summary, again, very hopeful and foundational era. I think the revised criteria are forward-thinking and reflect a transition we're in, which is exciting. It's nice to have this first world problem. And the ADRCs will be helpful on multiple levels to assess and refine the criteria and the approach, I think, including hopefully to be a more inclusive who, and figuring out how to do this and when to do this and how. And to continue to build on the infrastructure that we have. That's going to be very important. Be thoughtful about it, be methodical and rigorous. We need sharing, we need coordination and collaboration, and we need to do it with humility and respect. It's an awesome privilege we have. But it's very exciting. So it's a hopeful time, and thank you for your attention.
Thanks, Ali. Next, Dr. Cindy Carlson.
Thank you. Again, it's an honor to be here. I was asked to speak on gaps and opportunities, and I think all of us really are addressing gaps and opportunities. But I thought, first, I just want to thank the committee for the work they've done so Cliff and many in the room who have worked on these guidelines. I think that, or these criteria, again, this is really an advancement in the field to be able to move towards integrating these novel biomarkers, to be able to describe things clinically and biologically is extremely important. And so I think a lot of our comments are made to help refine these, but again, we don't want to underestimate all the work that went into describing these. It's great progress. So I'm really excited about the new guidelines or the new criteria. So just as far as disclosures, and I'll bring this up, so again, grant support, but also, as I'll mention, I am a member of the AGS, but did not make the statement I will talk about, and I'm also a clinical task force member, so I'm a bit advocate for UDS4. It's a little bias there. And I have to say at AAIC, when Bud and I walked into the room and saw there were going to be new criteria after we've been working on the clinical task force for 3 years, our heart sank a little bit, hoping it wouldn't upend all the things we had done. So I'm just going to bring in a few other perspectives. I really, really appreciate all the thoughtful comments that have been made so far, and I have to say I agree with everything that's been said so far. But I want to bring up a few things. The Dementia Nomenclature Initiative, which I'll talk about, was charged by NAPA, which I just rotated off from these last 4 years. I want to bring up some of the work they've done, a statement from the American Geriatric Society about the comments. So again, there are a few centers that are based in geriatrics. Wisconsin is one of those. So thinking about that perspective, and also some of the things from the clinical task force, and Dr. Autry has mentioned some of the ways we'll be able to use the new UDS4 guideline or criteria, hopefully to kind of study and see how the framework works. So the Dementia Nomenclature Initiative was founded because of the 2016 NIH, the ADRD Summit, that really called for some improvement in nomenclature, harmonization, and consensus around nomenclature. And so again, they thought that there should be a grouping of researchers and persons living with dementia and clinicians from different experiences to make comments and think about how can we have a better, more unified nomenclature. And so you can see that NAPA recommended formation of a committee, and then in 2018 a committee was formed. And so several people here I know have been a big part of that committee. So Ron Peterson, I think Jason Karlowish, and Sandy Weintraub and others. So again, to address this term, and they address the terms that were covered by NAPA, which include these 4 entities. So that's why there's only these 4 listed. So Alzheimer's disease, dementia with Lewy bodies, frontotemporal dementia, and vascular cognitive impairment. So again, they identified common issues we're all familiar with, the term Alzheimer's disease versus dementia, the confusion that people have around that. They address the issue that ADRD as a term, Alzheimer's disease related dementias, is problematic because not everything's related to Alzheimer's disease, and it's still a term we use commonly. And then again, just like we've heard today, they affirmed the differences, the need for differentiating biological versus clinical syndrome, which is great. But they also, again, the call was to really get input from everyone, from diverse groups. And so they got input from diverse groups, including some people living with dementia, and also with these groups got input on what kind of terminology should we use. And so what evolved with this, and again, those who are on the committee, feel free to jump up afterwards in the discussion and add to this, but again, really try to develop more of a communication framework to talk about this disease across different areas, so research into clinical practice, kind of bringing patients in that as well. And also address the issues of stigma, so avoiding the term, which I think hopefully we all do here, avoiding using the term demented, but what do we do with the term dementia, which still has connotations as well. So this is the framework that was proposed, and this was just published this week, so congratulations to the team on that publication. So I put the reference here. And again, I know that this has been presented at a variety of meetings, but thinking about, again, the issue about, as Dr. Autry brought up, we're talking to our patients, families, they're experiencing, or participants, they're experiencing certain things. So things like, what are the domains that they're having changes in? What is the severity of their illness? So those are things that patients and families like to hear, or at least it's more intuitive to them necessarily than a number staging for them. But then as scientists, we need to know the biology. We need to understand how the biology is driving these clinical relationships. And so again, this framework, again, putting it in a context of a communication framework, again, brings in broad stakeholders, not just the researchers, but the clinicians from a broad variety of backgrounds and patients and families. So how can we communicate the scientific advances we're doing in a way that's understandable to them and draws them in? And then that leads to the clinical syndrome, the pathophysiology, and what that care plan is going to be, which has been brought up several times. It's not just whether they qualify for lecanemab or not, but what that's going to look for them in their lives, how that affects their other comorbid illnesses, et cetera. So another perspective I wanted to bring up, so again, the dementia nomenclature, I encourage you to read that, think about those diverse perspectives, the stigma they might be having. And the American Geriatric Society, in response to the draft criteria, put out a statement that I'm sure that the committee members have read through. I don't bring up all the points that were brought up by the committee, but just wanted to highlight a few points that they raised that I think are worth discussing. So again, one of their top lines was that proposing this be used in clinical care is premature, and I think the committee's responded to that in some extent by saying that these are diagnostic guidelines or diagnostic criteria, not necessarily clinical guidelines. They also had concerns about the composition of the work group, again, and the lack of disclosure. So I think, again, as we're moving into this field of treatment, we do have to be transparent in our disclosures, whether it's for a lab-based company, pharma company, but we also need to have those partnerships because they're extremely important. So again, just being transparent, and then the need, as we all recognize, that we need more studies with people from diverse backgrounds, and diversity being very broadly meant as well, so that we can get better data on, to make sure that these pathologic progressions are actually truly similar or clearly delineated in each type of subgroup. So again, they brought up these issues, but a few other things too, and this is where, as geriatricians, I think we can kind of straddle the primary care world and the subspecialty world in that there's a broad range of clinicians. So to say that these guidelines or these criteria are going to be moved into clinical practice may need some more refining about what kind of clinical practice we're meaning. So again, a family medicine practice, they're not going to be able to keep up with all the criteria for new hepatitis markers and new cancer markers and hypertension categories. So how are we going to communicate that framework to these clinicians who are not dementia specialists? And then also, I think we've had good discussion here about use of biomarkers, during the session where we're talking about getting our biomarker results back to our centers and sharing those biomarkers back with our participants. Again, we're all still kind of struggling with how do we disclose these biomarker results responsibly. So thinking about that in our centers, again, it's a really good opportunity for us to develop biomarker, operationalize the biomarker standards, disclosure procedures that the agreed dementia group has developed and posted. But again, I think that concern from the group was that, if we as researchers who are thinking about this all the time aren't really sure how to best disclose and how to do shared decision making with their patients, how are we going to have these clinicians be thrown into this world of biomarkers and have to be able to make good shared decisions, knowing that their patients aren't coming just with Alzheimer's biology, but they also have other comorbid illnesses. And then the billing codes and all the other ramifications, and also the stigma that diagnosis being put in someone's chart about having someone have a diagnosis of Alzheimer's disease, not really knowing what that means and the implications on their insurability. So I won't spend too much time on this, but thank you, Dr. Attree, for going through our new recommendations. Thumbs up. So again, we've broken up in the CTF, so Clinical Task Force. Again, we've been working on these new forms, and a lot of you who are do consensus conferences are used to the D1 form, where we identify what are the clinical symptoms, clinical syndrome they have, what's the biologic cause, and so now we've separated those out so that we can more clearly identify what is the clinical syndrome, what's the biologic cause. And so like Dr. Attree mentioned, again, we will be it'll give us a chance to test this new framework. So I think again, we don't have the clinical stages, but like Dr. Attree mentioned, we have newer stages. We have subjective cognitive decline, which is new, mild behavioral impairment, and clarified parsing out of details of impaired, not MCI. So hopefully we can see how do those clinical syndromes map onto these biologic constructs that are proposed with the new criteria. The other thing, as we've mentioned, is that the ADRC program, again, we as a whole, those of us here thinking about biomarkers, clinical practice, diagnostics, we have the opportunity to help inform clinicians and other groups about how to best do disclosure services. So again, I know that's part of the new RFA for the Alzheimer's centers is to have these disclosure services. I think my colleagues, Dr. Clark and Chin, who've been working on this, again, how can we best develop practices so that we can share that with clinicians? How can we best develop practices on how to approach these diagnostics and share that with the clinical teams? So some closing thoughts. Again, I think that the framework is great advantages over time as we understand the biology, but can we move that, can we study it in that research and clinical research framework and test it before we push it out into clinical practice, gathering data from the UDS4 and seeing how does that clinical syndrome really map onto the biology, and then working to integrate this communication framework to do some PR within our own field as we push this out to clinicians if they feel like they have buy-in and understand. And then we have a great opportunity to think through what are the best practices that clinical fields are needing from us as a centers program to help develop so that the clinicians can feel like they have the tools they need to provide good care around the biomarkers and this changing diagnostic framework. So I'll stop there. Thank you.
Thank you, Cindy. And Dr. Wilcock is in a cab in the middle of traffic. We hope she will join us perhaps in time for the discussion, but in preparation for this, we have her recorded presentation, so we'll see that now.
Good morning, everyone. It's great to be giving this talk to you all today at the ADRC meeting. So I was asked to speak about adding the I and the V to the ATN criteria. And since this is a new idea, really talking about the challenges, but also the opportunities that we have with respect to thinking about this. So just my disclosures, I do a little bit of consulting and collaborate with some companies. None of that is relevant to today. So first of all, why is it important that we actually consider the I and the V, the inflammation and the vascular contributions to dementia? And I think this is important because a lot of the data that has come out over the last kind of 10, 15 years is really pointing to a key contributor of these factors with respect to the clinical syndrome of dementia. So we know that there is increasing evidence to support inflammation having a significant role in Alzheimer's disease. And I think this comes from animal studies, but also human studies. So we know that a number of the genetic risk factors that have come through from our GWAS analyses have identified key inflammation-related genes, such as TREM2, CR1, and CD33. There's also evidence that there's inflammatory processes that are altered. So IL-6, for example, is a pro-inflammatory cytokine that's been shown in a number of studies to be elevated in the CSF and the plasma of AD patients. Furthermore, with respect to vascular contributions, I really do think a seminal paper that reinforced this vascular contribution came from Zoe Vanatakis and Julie Schneider studying the ROS-MAP cohort, where they showed that cerebral small vessel disease has an additive effect on cognition when it's comorbid with Alzheimer's. And so if you look at the graph there on the right, for a certain amount of Alzheimer pathology, so that's on the x-axis, higher number is there's more severe AD pathology in the brain. You can see that with the black line, that is no infarcts, no microinfarcts or macro. And then, and so you have a certain level of global cognitive function for that given amount of AD pathology. But what you see is that if you now add macroscopic infarcts, no microinfarcts, you have a worse cognitive function for the same amount of AD pathology. And then likewise, if we now add macro and microinfarcts, you can see that again, you have worse cognitive function for the same amount of AD pathology. So when you have comorbid Alzheimer's with small vessel disease, you need less Alzheimer pathology to show a certain level of cognitive functioning. So now the challenges. So the challenge with adding a V is that we're not talking about one single pathologic entity. In Alzheimer's disease, we're talking about plaques and we're talking about tangles. But with respect to the V, that V represents many, many different pathologic hallmarks of vascular disease. So we could go anywhere from microinfarcts, microbleeds, small strokes, transient ischemic attacks, and then all the way to CADASIL, small vessel, large vessel disease, ischemic strokes, hemorrhagic strokes, cerebral amyloid angiopathy can also impact small and large vessels. And so we're likely not going to be looking at one single V marker with respect to biomarkers. We're going to probably be needing to have specific biomarkers for each of these vascular pathologies. And so it's really important that we develop clinical outcome and biomarker measures that match these specific vascular pathologies. There's also a number of challenges with respect to adding I to the ATN criteria. The biggest challenge here is that there are so many different activation states that have been linked to microglia. On the right there, you just see a figure. I'm not going to talk about any of this, but what you can see is that there are a number of identified microglial states, and each of these states is associated with both upregulation and downregulation of specific inflammatory mediators. And so we know that from our mouse studies and a small number, I would say, of human autopsy studies, we know that some of these states may be very beneficial at early disease stages, but the same state could be detrimental late in the disease. So interpreting an I could be very different whether you're looking at early stage versus late stage disease. We also know, based on a lot of human data that's been coming out recently, that GFAP and YKL-40 are really, I think at this point, the front runners when it comes to inflammation fluid biomarkers. But these are astrocyte derived, they're not microglial derived. That doesn't make them any less important, but I do think we need to consider that we're looking at an astrocytic response, and that response may be secondary to a specific microglial response in the brain. It's also very unclear what state these markers are associated with. So if we see elevated GFAP, what is that really telling us about the state of the inflammation in the brain? And the same with YKL-40. So I wanted to put this up. I think there are some candidate biomarkers. We just need to better understand them with respect to what they are telling us about disease in the brain. What are they telling us about inflammation? So for example, a lot of the GFAP literature that's out there right now really associates GFAP with the amount of amyloid in the brain. But there's no doubt that the GFAP is derived from the astrocytes. And so how is that relationship reflecting an inflammatory state in the brain? Microglia, we know that soluble TREM2 may be a very good indicator of microglial reactivity in the brain. Other candidates, such as the inflammatory cytokines, are going to be harder just because there's so many peripheral sources of those biomarkers that really trying to identify brain-derived cytokines is going to be important. Likewise, with respect to fluid biomarkers of the VCID, there are some candidate biomarkers here. I think actually GFAP may reflect some cerebrovascular disturbances, especially since we know astrocytes surround the vasculature with their end feet. And so if there's any injury to those astrocytes, they could be releasing GFAP into the plasma. Also, NFL has been linked to small vessel disease, and that's something that Sudha Seshadri's group at San Antonio are pursuing in the MARC VCID consortium. We also have identified PLGF, as well as there's some evidence for PDGFR beta. And then we may be able to look at endothelial-derived exosomes to identify specific biomarkers. I just want to be very brief here and show you that recently it was published by Jason Hinman and colleagues, and this was a MARC VCID production, that placental growth factor in the plasma may be used as a diagnostic for the V. You can see the ROC curves here with respect to CDR and physicas, as well as the UDS score. And so we see an 89% accuracy with diagnosing vascular dementia and a 74% accuracy diagnosing vascular cognitive impairment. Just to show you, work from our lab has suggested that PLGF is expressed in the brain. It's elevated in cases of severe small vessel disease. And not only is the protein increased in plasma, but we see it increased in brain and in its gene expression in brain tissue. So what are the solutions? The solutions are going to be more autopsy studies with matched antemortem biofluids, mouse models and iPSC studies to identify fluid biomarkers that match specific subtypes of inflammation and specific types of cerebrovascular pathologies. We need to identify CNS-derived fluid biomarkers like GFAP and YKL-40, less so with the cytokines. We need improved technologies so that maybe we can optimize brain-derived exosome approaches that will then broaden the potential biomarkers that we can assess. And we also need to think about better gold standards, so better PET ligands for glial reactivity and also better MRI sequences to detect specific small vessel pathologies. So with that, I will thank you for your attention, and I look forward to discussing more in the panel.
Great. If the panelists could come up to the dais, please. Okay, thank you, all of you, for some very thought-provoking presentations. I think I'll take the prerogative of starting with the first question, one that was, I think, raised by you, Cindy, which is the impression on the part of many members in the community that although the criteria say very frequently that they're not attempting to dictate clinical practice, they are providing clinical diagnostic criteria, which the argument has been made by default is going to affect clinical practice, even though the details of that have yet to be worked out. So I'll ask to what degree the panel feels like the attempt to move into the clinical arena potentially is premature. Cliff, I'll ask you to comment first, because I'm sure this was a hot topic of conversation.
Sure it was. And so, I mean, what we've tried to do is have a foot in both camps. We've tried to straddle clinical and research. You know, in terms of, to address your specific comment, the kinds of things that we've tried to avoid is discussing specific triaging algorithms. Do this test. If the result is this, then this, et cetera, et cetera. So we've avoided discussing or describing specific treatment triaging algorithms. We've avoided discussing or describing so as not to appear to recommend specific assays or specific commercial products, which any clinical guidance is going to have to do. At the same time, if we're defining Alzheimer's disease on the basis of biomarkers, it is hard to avoid some degree of specificity. It can't just be a vague hand wave. I mean, there has to be some specificity there. So we've tried to straddle that, we've tried to straddle that border, and we've done the best job we can.
Other panelists want to comment on that, or?
I think, again, I totally agree. I think that we need to be able to solidify the underlying pathophysiology. It's going to help guide our treatment. I think we need to move some of those criteria into clinical practice, definitely. I think what we're hearing from people getting pushback is that what's walking into their clinic, or there is a person with comorbid illnesses, cognitive concerns. They're not walking in with the biomarker profile like an ADRC participant who's been in clinical core and followed longitudinally. So I think the challenges of moving that into clinical practice are that as an Alzheimer's Centers program, we're starting where we have these really well-characterized participants, their biomarkers, their cognitive trajectile, whereas to put it into clinical practice where you have someone who is the first time seeing someone and they're MoCA's 12 and they're trying to figure out, is it because of their sleep apnea, et cetera. I think it's that issue of putting that biomarker in that context and forcing them to use that biomarker when there's all these other factors going on that they feel a little lost already, where to start with that. And then now to have to use this biomarker and figure out how much that's contributing. I think that's where the pushback's coming from.
Thank you, Cindy.
And just a quick comment. I think it's wonderful. We are trying to build the bridge between research and clinical care. But we need to remember research on whom and clinical care of who. And it's wonderful that we are having these discussions at this early stage, I think. I mean, it seems early. But definitely it's a cyclic process. And the bridge needs to be robust between the research and the clinical. And still, it's just the beginning.
Thanks. Maybe time for one more comment. Ali?
Yeah, I agree. I think very forward thinking. We need this, and I think the ADRCs and other venues are the way to be able to assess and validate it. At the same time, the clinical syndromes matter when we treat patients symptomatically. That really matters. I'm a subspecialist. I haven't had access to these things. Put up your hand if you've ordered, GFAP in clinic. Anybody? Or I mean, but I think those are the kinds of things that really concern me. And being on all sides, having been a care partner twice in my life. Actually, primary care partner. So I think those are the things we have to be cognizant about, but they are forward thinking. Appreciate it.
Great. We'll start with one online question, and we'll go to folks in the room.
Great. So this is a question from Dr. Crystal Glover at Rush. It's to Dr. Maestre. How will the considerations associated with diverse communities be incorporated, both written and in practice, into the seemingly established and revised NIA-AA framework?
Thank you. I think that we just need more studies. We need to include more people, and not only based on the OMB classification. I think that having a broader perspective, but I think we need to listen to our population. I think that's the main when people ask me, what is the piece of advice to including underserved or underrepresented, I say you have to listen. You, as a researcher, need to listen what they expect, what they want. And I think that that's the only way, listening and responding to all those beliefs, to those expectations, that we are going to have really the broad representation that we need.
Thank you. Please state your name and your affiliation.
Yeah, sure. Jason Karlowicz, University of Pennsylvania. I was wondering if we could spend some time on I think the criteria that would say someone has Alzheimer's who has no evidence of cognitive impairment and is amyloid positive on PET, that they would be labeled with Alzheimer's, right? I was wondering if we could drill down on the evidence to support that. It's certainly a very important category to put someone in, and it will certainly change how we count the disease, et cetera. So there's certainly provocative evidence, but I wanted to develop the two streams that Mike and Dr. Maestra raised. Mike, you raised the results of clinical trials that have manipulated amyloid and shown that that translates into clinical effects. I think there's certainly provocative evidence from trials, but the trial I would want to see would be a trial that enrolled individuals who are cognitively unimpaired and had elevated amyloid and randomized to drug or placebo, and after that, we showed clearly that their clinical course was altered. And I don't think we have that kind of trial yet to conclude that, make that conclusion. There's provocative evidence from the studies in people who have MCI and dementia, many of whom also had to have tau, but the data out of our trials I don't think is like the data that allowed us to conclude that lowering systolic blood pressure in an asymptomatic individual with a drug defined hypertension because we reduced the risk of stroke and other problems. The other stream of data was developed by Dr. Maestra, which is looking at amyloid positivity alone to predict long-term outcomes. And there are some diseases where an abnormality in absence of any symptoms is used to label someone, such as hemoglobin A1C. No need to have any other symptoms or problems, but that alone, above a cutoff, labels you with diabetes. I think your talk suggested to me that, again, there is very provocative data that being amyloid positive alone raises one's risk, but I saw you expressing skepticism of the robustness of that data to apply across humans in general. And so with that, I would like us to explore whether we're ready to say that someone who's cognitively unimpaired and A positive alone on PET has Alzheimer's disease. And please, I welcome now the discussion of that. Thank you.
And I will just say, if we could just hit the one top note so that we can have questions. It's worth its own day-long session for sure.
And then maybe we should give it a day's session.
And we should.
Because
no
this is an
question.
enormous
So
public health implications.
that is a suggestion that should come out of this. No question. Okay, so you first.
Okay, so I would say that the beta amyloid elevation is the first detectable change in the AD continuum. Two studies that I would refer to. The first was published by Mike Donahue looking at the ADNI data, looking at those who had elevated amyloid versus those who did not, who were cognitively normal at the outset and followed for 10 years. Those individuals who had elevated amyloid had a cognitive decline that was associated with that amyloid. The second study I would mention is the correlation between A4 and the LEARN study. Remember, in A4, individuals were asymptomatic, elevated amyloid at a set threshold, who then were randomized either to treatment or placebo. But in the LEARN study, these individuals screen failed for A4, but were individuals who were concerned or had a family history, but were amyloid PET negative. And very clearly, those individuals who were in LEARN, who were amyloid PET negative, did not have a progression, whereas those who were elevated with amyloid in the A4 study did have a decline, regardless of treatment or placebo. So in my mind, at this time, amyloid is the earliest detectable change. And should the additional pathological features develop, including tau, but also vascular and inflammatory changes, their risk of developing or your confidence in making that diagnosis goes up multifold. But elevated brain amyloid, in my opinion, defines the earliest stage of Alzheimer's disease.
Great. And Dr. Maestra?
Yeah, I think I tend to defer based on the Colombian data showing dominant mutations that should be expressed and are expressed as amyloid positive at 30 years of age. And then 30 years later, they still don't have mild cognitive impairment. And they need the second hit or a third hit in order to have a manifestation. So I think it's too early. Also, defining a condition is different from diagnosing a disease. In Spanish, we don't have a difference between disease or illness. And still, I have to think twice about this. So I think still it's too early.
Thank you for a very provocative question, which is what we want. Yes.
My name is Pinar Koskum from University of Kentucky. So my question is actually about, this is actually beautiful, having a diagnosis and staging criteria. However, in real setting, most of the time we see a mixed pathologies. So most like DLBs are contaminated with AD pathology. So how this staging is going to affect in terms of like this algorithm is going to affect the staging and the diagnosis?
Cliff, do you want to?
Sure. I mean, the thing you've just articulated is exactly the reason to stage the Alzheimer's disease. We're staging one disease. Most elderly people who are impaired have more than one disease, right? It's well established. We all know that. But we want to be able to diagnose and stage one of those causes. Take other areas of medicine. The common cardiovascular risk factors are diseases that occur in old age. There's a staging scheme for diabetes. There's a separate staging scheme for hypertension. They're not the same thing, but you treat a disease in a disease-specific manner. So you need to be able to diagnose and stage a disease, even though most people who are impaired have more than one disease.
Thank you.
Sudha Seshadri, South Texas ADRC. And actually, Cliff, to address what you just said, when we talk about staging people for risk of myocardial infarction, we don't only go by either their blood pressure stage or their hyperlipidemia stage or their diabetes stage. You have to take all of that into account with a general cardiovascular risk score or a stroke risk score. So there is, of course, somebody who has dementia. You're trying to see what are the different streams that may be accounting for that dementia. We know that having Alzheimer's doesn't protect you from having either vascular and perhaps not even from having Lewy body, right? These coexist. The pure is a mythical beast. When we are saying target engagement, or we are trying to define the different pathologies, if you can do that at a peripheral level with a plasma biomarker, a skin biopsy, a PET scan, that's great. But when we are talking about prediction and prognosis, I would agree with the last two speakers that what we are interested in is the clinical cognition dementia, right? Because that's what matters to the patient. And so one of the things we are recognizing in the last few years is that the A and the T are somewhat complex, and we need to refine those, at least the T biomarkers. Equally, we know that the inflammation is complex. It depends on the stage, good, bad. The vascular is complex. They're not going to get one biomarker for it. In addition to those that were discussed, there's BNP, GDF15, MMP, ST2. So perhaps what we need is the recognition that there may be Alzheimer's diseases, that there are vascular diseases, and perhaps we need to revisit something like proteomics to cognition to have biomarkers, at least for prediction and prognosis. I agree with the previous two that we are sort of entering a dangerous space if we call everybody with a biomarker as a disease. Is that what our patients want? Thank you.
That may not be what patients, the first thing that comes to mind, but as scientists who are trying to treat patients, it darn well better be what doctors is top of mind for doctors.
Yeah.
You're never going to cure or treat a disease that you can't define, you can't measure, and you don't understand.
So, I do think, I mean, one thing I really like about the staging, but the clinical versus the biologic, is that I know you talked, Cliff, about the gray line is kind of the typical course, and then you see that those who have more advanced clinical, there's obviously something else going on. So it gives us a chance to fill in the gaps. What are did they have late? Did they have DLB? There's something else going on, and as the biomarkers evolve, we'll be able to chip away at looking at how much does this contribute to the disease progression. So I think that model is good in that way. I think it's the labeling of a person with that disease that's the challenge. I think saying this person has these biomarkers, there's some gaps in what we understand about their pathology, we need to fill in those gaps. And then on top of that, as clinicians, we have to look through what are the other factors besides underlying neurodegenerative condition, their untreated sleep apnea, other medications, et cetera. So that's the other layer that we're not going to get through biomarkers.
Okay, we have, Ali would like to make one more comment.
Yeah, I agree. I guess what I was saying is that we just haven't had, as a clinician who takes care of people, who's involved with the research, I don't think I have the familiarity. I haven't had the biomarkers available to me yet. And if I'm struggling with it, I think other people will struggle with it. I think that's what I'm saying. And I think it's amazing the work that you've done. You're trying to pull us along, and it's the right direction. It's just I think this component of it is difficult.
All right. Gwen?
Hi, Gwen Garden, UNC. I think perhaps the better analogy than hemoglobin A1C is maybe the PSA, because that is a biomarker for prostate cancer, and yet we don't really always know, will the person get prostate cancer? We don't really know if they got prostate cancer, clinically, and we don't know if they even had it clinically, if it needed to be treated. So I think that might be a better context. And another reason why I think it's a better context is because it can be sort of tied in with this concept of stigma, because cancer carries with it a lot of stigma. And I do worry about stigma a lot, both in terms of recruiting research participants and in terms of what it might mean to people who have in their medical record that they have, stage 1 Alzheimer's disease. So I guess my question is to Gladys, but maybe it's to anyone. In your experience, does that concern for stigma, does it rise to the level of potentially negatively impacting our research capabilities?
Thank you for the question. In South Texas, and I have to recognize my limited cultural experience addressing stigma. In South Texas, people want to know, they are so stigmatized. The migration, the poverty, the Mexican American, the colonialism, and this is like, well, I knew we had more diabetes, more cancer, more pregnancy, more, and now we have more Alzheimer's, what else?
Yeah.
So, however, what they want is trust. Doctor, do you know what you are doing? When you look at these images, when, all these tests that you guys done, I know you know. And that's why I have to be humble enough to say I'm a researcher, as a clinician, I have to say, we believe, we suspect. Still, we do not know how is this going to affect our Mexican Americans in South Texas.
Thank you. Dr. Weintraub, and I'll just warn you all, we're not going to get to everyone because we only have 3 or 4 minutes. So.
Okay, I'll talk very quickly.
Yeah.
Thank you so much for bringing up this topic, and thank you, Cindy, for giving a shout out to our dementia nomenclature paper. I'm delighted that we're having this discussion, and the whole idea behind our initiative is to have clinicians talk to research, talk to the people affected and the people who take care of them and the people who pay for their insurance. Thank you.
Okay. Dr. Charlie DeCarli, and a quick question. Two phrases that are not really usually in the same sentence.
Well, let me just start off by saying as I get older, my brains are failing as fast as my hair is receding. So this is for Cindy and the group as a whole. How are we going to use this matrix, this diagnostic matrix? I know, Cliff, and you know, you're doing fantastic work, but how are we going to use it? Is this going to be part of advancing the science and advancing the clinic within the clinical task force, or are these two things, because you brought this up, Cynthia, these two things completely disparate?
That's a great point. So as soon as the criteria came out, we revisited it at the CTF and thought, could we put this diagnostic chart, this framework, into the CTF, into the UDS-4, and we didn't feel like it was quite ready for that, but we thought I think the data will overlap enough. You can link, as Ali pointed out, you can link the clinical stage to the numeric staging. You can link the biomarkers to see, but it'd have to be some analyses done to see, do people in our cohorts fit this trajectory? Are there more in another group than another? So it's not going to be an easy fill in the box in the UDS-4. Is going to have to be analyses, through our centers program to see how do these people map, and maybe the new investigator awards that Bud talked about will have give extra points for those who can see if it maps out.
But I think we do agree that we need to be forward-thinking about how to align the framework with the UDS-4, and that has to happen right away. It has to happen to the benefit of the criteria and to the benefit of the ADRCs. So, sorry guys, last question.
Oh, thank you. Mary Sano from Mount Sinai in New York. I've never had the last question, the last one. But I just wanted to say, I think this effort's really going in the right direction. The precision is great. But I think it's important to remember some of the things that Cindy brought up with the AGS commentary. We've really alienated the clinicians, and I'm worried that our UDS-4 is again so not sufficiently simple that we might, in the end, be able to find a few items that could predict what a clinician should ask or do to know what to do next. And I think what we really need to do is to give to that clinical community the knowledge and the confidence to be able to do the clinical diagnosis. Just wanted to comment that the work that Hiroko Dodge did with our UDS last round was to find that using AI, the one thing that predicts was clinical judgment. But you don't get to clinical judgment until you know which of our 5 hours of questions are the ones that give you the best clinical judgment. So I think we really need to think precisely about how to get that and match it into the great biology that we're learning about.
Just comment briefly.
Thank you.
I think, one thing, the last ADRC meeting, we talked about, the ADRCs moving towards having more clinical care because, like the cancer centers, we're going to be doing treatment, et cetera. And one thing we could do as a centers program is to get input from clinicians, what kinds of clinical diagnostics decision-making they want, and then for us as a centers program to see what are these key elements that clinicians might be able to use, pull those out, put them back.
And to what you were saying, Mary, I think as a clinician, there's two states that you could be in. You could either be humble or you're just about to become humbled. So, all right.
I love that. All right, so I think two things. Please, people in the room, take a look at the criteria, put comments in there. I think we all need to as I said, have responsibility for that. We also, the clinical task force, who was supposed to be like a 10-month job, and we're now on year 3 of weekly to biweekly meetings, so I'm hesitant to say this, but I do think discussion about how to begin to facilitate alignment should happen yesterday. So thank you very much, and it's been a great morning.